All right, good afternoon, students. So, the topic of our lecture today is Propaedeutics of Internal Medicine as a subject, and also examination of patients with respiratory system pathology. So, this lecture will consist of two parts. We will talk about those things which you already passed, about history of the illness, about symptoms, signs, syndrome, about diagnosis, about examination of the patient. And also, in second part, I will tell you information about respiratory system examination. So, as I mentioned, first part is dedicated to examination of the patients, symptoms, signs, syndromes, health history, subjective examination, objective examination, and diagnosis. So, generally, modern diagnosis combines the thinking of the patient's health history, a physical examination, and laboratory and instrumental examinations. Diagnosis in medicine is the determination of the nature of the disease. So examination mainly consists of subjective and objective part. Subjective examination is inquiry or questioning of the patient. The parts of this inquiry are passport data, complaints, history of present disease, and history of patient's life. Objective examination is divided on main methods and additional methods of examination. Main methods are called physical examination, and they consist of general examination, inspection, palpation, percussion, and auscultation. And additional methods, most often, which we are using in our practice, are laboratory and instrumental. So, there are complaints of the patients, and they consist of symptoms and signs. So signs and symptoms are abnormalities that can indicate a potential medical condition. So a symptom is a subjective evidence of a disease observed by the patient and cannot be measured directly, for example, back pain or fatigue. And a sign is objective evidence of a disease, so objectively observable by others, for example, a skin rash or lump. So the key difference between signs and symptoms is who observes the effect. For example, a rash could be a sign, a symptom, or both. If the patient notices the rash, it is a symptom. If the doctor, nurse, or anyone other that the patient noticed the rash, it is a sign. If both the patient and doctor notice the rash, it can be classed as both a sign and a symptom. So there are three main types of symptoms: remitting symptoms, chronic symptoms, and relapsing symptoms. Remitting symptoms is when symptoms improve or resolve completely. They are known as remitting symptoms. For example, symptoms of the common cold may occur for several days and then resolve without treatment. Chronic symptoms, these are long-lasting or recurrent symptoms. Chronic symptoms are often seen in ongoing conditions such as diabetes, asthma, and cancer. And finally, relapsing symptoms or recidivism. There are symptoms that have occurred in the past, resolved, and then return. For instance, symptoms of depression may not occur for years at a time, but can then return. Some conditions show no symptoms at all. They are asymptomatic. For example, a person can have high blood pressure for years without knowing, and some cancers have no symptoms until the later, more aggressive stages. So, symptom by presentation. What patient can tell you? For example, my tooth hurts, or my abdomen hurts, or my chest hurts, or I feel chills, fever, or dizzy, or I can't breathe normally, I can't move on one side, arm or leg, I can't pass a bowel action normally. And you have to recognize, and of course you have to understand what is wrong with your patient. So, a medical sign is an objective indication of some medical fact or characteristics that may be detected by a patient or anyone, especially as a physician, before or during a physical examination of a patient. Some signs may have no meaning to the patient and may even go unnoticed, but may be meaningful and significant to the healthcare provider in assisting diagnosis. Doctors are trained to pick up signs that an untrained individual might not see as important. So signs fit into the following categories: prognostic signs, anamnestic signs, diagnostic signs, and pathognomonic signs. Here are different signs. For example, sign which is jaundice or palmar erythema on the hands, or hypersalivation, or clubbed nails, or ascites, or cough, or high temperature, and hemoptysis. Next is syndrome. So syndrome is defined as a recognizable complex of symptoms and physical findings which indicate a specific condition for which a direct cause is not necessarily understood. So syndrome can be as independent disease, for example, Cushing syndrome, Raynaud's syndrome, or Wolff-Parkinson-White syndrome, or as a part of disease in peptic ulcer, for example, is combination of Spain syndrome and dyspeptic syndrome. In hypertension, may be combination of asthenic syndrome and cardiac syndrome. Now, diseases may be classified by cause, pathogenesis, or by symptoms. Alternatively, diseases may be classified according to the organ system involved. So this is often complicated since many diseases affect more than one organ. The most known and used classification of disease is World Health Organization International Classification of Diseases, or ICD. A chief difficulty in nosology is that diseases often cannot be defined and classified clearly, especially when cause or pathogenesis are unknown. Those diagnostic terms often only reflect a symptom or set of symptoms, which is syndrome. So classically, classification of human disease derives from the observational correlation between pathological analysis and clinical syndromes. Today, it is preferred to classify them by their cause if it is known. Now, health history. Once Giorgio Baglivi said, "Let the young know they will never find a more interesting, more instructive book than the patient himself." So, a medical history, it is information obtained from the patient to aid in establishing a medical diagnosis and developing a treatment plan. So health history have next parts: subjective examination, objective examination, laboratory and instrumental methods of examination, their results, and treatment plan. So first is inquiry or questioning. I mentioned that already, that it consists of passport data, complaints of the patient, anamnesis morbi, which is history of patient present disease, and anamnesis vitae, which is history of patient's life. So passport data, of course, must include the name of the patient, date of birth, age, address, occupation, date of admission to the hospital, and by whom is directed to the hospital. Complaints of the patient, it is sometimes also referred as presenting problem on admission, or reason for presenting. So chief complaints are subjective statements made by a patient describing the most significant or serious symptoms or signs. So here on this slide, you can see complaints of the patient. For example, due to respiratory system abnormality, specific complaints may be next: dyspnea or breathlessness, cough, hemoptysis, and chest pain. Non-specific here are fever, weakness, malaise, and decreased appetite. In second table, we can see cardiovascular system specific complaints, which are pain in the heart region, intermissions, palpitation, dyspnea, asphyxia, and non-specific here are a little bit similar to respiratory system. They are fever, sweatiness, also fatigue, headache, dizziness, sleeplessness, etc. So, complaints, when we talk with the patient about the complaints, we always have to ask about the localization of the problem, irradiation, the nature, the character, degree of expression, severity, relationship to time, in which condition arise, and the factors that provoke and elevate the surface they are combined with. So on the right of the slide are complaints connected with pain. So what questions doctor have to ask? For example, where exactly is pain? What were they doing when the pain started? What does the pain feel like? Does the pain go anywhere else? Associated symptoms maybe was nausea or vomiting. Time duration, for how long have they had the pain? Does anything make the pain better or worse? Next part is, of course, anamnesis morbi. So anamnesis morbi includes data concerning onset and progresses of the present disease until the present. The patient should be asked about the first sign of the disease and their dynamics, about exacerbation, remissions, and their duration, about possible previous examinations and treatment and their results in chronological order. And finally, the cause of the present hospitalization should be noted. So history of present disease consists of next questions: the time of the disease onset, the cause if known, the first symptom and their character, previous examination and results if any, and of course treatment results if any. Next is anamnesis vitae, is a part of the medical history of the patient in infancy, childhood, adolescence, and adult. So the information obtained during collecting of the anamnesis vitae is very important for understanding of character, cause, and conditions of the disease onset. So history of the patient's life consists of next parts: family history, social history, pharmacological anamnesis, allergic anamnesis, gynecological anamnesis if it is woman, epidemiologic history, and personal history. Now, objective examination of the patient. There are main methods and additional methods with what was mentioned already. So main methods are called physical methods of examination, and they are inspection, palpation, percussion, and auscultation. So first is inspection. So it is visual assessment of the patient. Examiner uses the sense of sight and concentrate attention on thought, persistent, unhurried visualization of the patient. So where it can be done? Anywhere on the body. And inspect each area of size, shape, color, symmetry, position, and abnormalities. If possible, compare each area inspected with the same area on the opposite side of the body. Next is palpation. So it is determination of the nature of the skin surface, its temperature, humidity, consistency, form and position of the organ, its size, feeling that the patient has, for example, pain. Where it can be done? Anywhere on the body. Next is video, how look like possible way of the palpation, for example, of the abdomen. Next is percussion. So percussion is a method of tapping body parts with fingers, hands, or small instrument as a part of physical examination. It is done to determine, first of all, the size, consistency, and borders of the body organs, and also the presence or absence of fluid in body areas. So percussion of body part produce some sound. like playing a drum. The sound is a sign of the type of tissue within the body part or organ. So there are different sounds which may be heard during percussion. Timpani, for example, is clear, loud sound, and it's absolutely normal above the abdomen. Resonance is normal sound produced above the lungs. Hyperresonance above the maximum inspiration of the lungs. Dullness is natural sound for the liver or heart, and flatness may be heard on the arms or thin. Now let's take a look how look like possible way of percussion. Next method is auscultation. So auscultation is a term for listening to the internal sounds of the body, usually using a stethoscope. So auscultation is performed for the purpose of examining the circulatory system and the respiratory system, as well as the gastrointestinal system. There are two ways of auscultation. It may be direct by ear or indirect using stethoscope. So areas where we're doing this examination, of course, are heart region, lungs, and abdomen. So how look like this examination possible way? Now, there are a lot of different laboratory and instrumental methods of examination. For example, laboratory methods of examination are complete blood count, urine analysis, which is also called general urine test, stool test, biochemical methods of examination of the blood and urine, for example, coagulogram, blood hormone test, determination of tumor markers, test of blood and other biological materials for infection diseases, allergological examinations, toxicological examinations, cytological examination, and parasitological examinations. Instrumental are next radiological, endoscopic, ultrasound, and methods of recording the electrical activity of organs. For example, electrocardiogram or electroencephalogram. Radiological examinations are next one. Radiography, radioscopy, tomography, computer tomography, magnetic resonance imaging, fluorography, and positron emission tomography. Endoscopic methods are fibrogastroduodenoscopy, colonoscopy, rectomanoscopy, rhinoscopy, laryngoscopy, bronchoscopy, laparoscopy, arthroscopy, colposcopy, and videocapsular endoscopy. With help of ultrasound, we can examine the condition of the liver, gallbladder, pancreas, spleen, lungs, kidney, bladder, prostate, female genitals, also joints, heart and blood vessels, mammary gland, and of course to check for pathological condition in the fetus. And there are also morphological examinations. They are not widely used in general practice, but still you have to know about them. And here we have cytological examination, histological examinations, and immunohistochemical study. So cytological examination is performed by puncture and biopsy of the organ, joint, tumor, or abdominal cavity. Histological examination is performed by scraping and imprints from the surface of organs and tissue, for example, cervical gynecological examination, or ulcers, or fistulas, or erosion and wounds. And finally, immunohistological study is performed from biological fluids such as sputum, urine, juice of prostate glands, secretion from the breast, etc. So there are basic tests that should be done for each of your patients despite the problem with which the patient came to the hospital. They are complete blood count, urine analysis, blood chemistry, but you always have to specify the indicators which you want to check in blood chemistry, also ACG and stool for oval or parasites. So then you also have to specify additional tests to confirm the diagnosis and indicate necessary expert advice. For example, if you suspect some respiratory system abnormality, best will be to add to laboratory and instrumental methods, such methods like examination of pleural fluid, sputum examination, and arterial and venous blood gases. Instrumental may be here X-ray of the chest, spirometry, bronchoscopy. In cardiovascular system disease diagnosis, you can check myocardial necrosis signs in blood chemistry and instrumental such as echocardiography, electrocardiography, phonography, rheography, and angiography. So, subjective and objective examination leads us to the diagnosis. So, diagnosis is a major component of the procedure of a doctor's visit. There are three main types of diagnosis in case history of the patient: preliminary, clinical one, and final. So preliminary mainly is based on the obtained information after inquiring of the patient, and physical examination, which is inspection, palpation, percussion, and auscultation. Clinical diagnosis is based on the previous signs and symptoms mentioned in preliminary one, and also additionally with results of instrumental and laboratory methods. And final is last diagnosis, which is based, of course, on the information mentioned in preliminary and clinical, and also the results of the treatment. So final diagnosis has next structure. It consists of the main disease, complication of the main disease, and concomitant or concurrent disease. Example here is, for example, patient is hospitalized with non-hospital pneumonia of middle lobe of the left lung, severe course. Complication due to that problem is exudative left pleurisy, pulmonary insufficiency first grade. And finally, in the same time, patient is suffering from chronic atrophic gastritis of the body of the stomach, Helicobacter pylori negative. Yes, your patient is not hospitalized with this problem. That is why it's not mentioned as a main disease, but still you have to mention it because your patient has it. Now, there are subtypes of diagnosis: radiology diagnosis, laboratory diagnosis, tissue diagnosis, and differential diagnosis. And now, next part of our lecture is dedicated to examination of patients with respiratory system pathology. So here we have, first slide is about anatomy of the respiratory system, and I want to refresh your knowledge a little bit about anatomy and physiology of the respiratory system. Now, first of all, of course, respiratory system consists of nasal cavity, nostrils, pharynx, epiglottis, larynx, trachea, primary bronchus, pleural cavity, which covers the lungs, right and left lung, and of course, diaphragm. So let's watch a video about physiology of respiratory system.
As we breathe in air, the oxygen molecules enter the nostrils and travel downwards through the pharynx and trachea to finally reach the bronchi. From each bronchus, oxygen travels into the lungs. Within the lungs, the bronchus divides repeatedly to form bronchioles. Oxygen travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. A section of one alveolus shows the presence of numerous alveolar chambers with pores. Blood containing RBCs is seen flowing through the capillaries. The oxygen molecules from the alveolus diffuse into the capillary and then get absorbed by the bluish-purple RBCs. This causes oxygenation of the RBCs, and a transition in their color from bluish-purple to red is observed. The blood moving into the alveolus contains RBCs and carbon dioxide molecules. These molecules are released into the alveolus. The carbon dioxide collects in the alveolar chamber. And then from the alveolus, it travels through the bronchioles into the bronchus, which finally reaches the trachea and is breathed out through the nostrils.
Well, so as was mentioned already, there are specific and non-specific complaints due to respiratory system disease. The main specific complaints are dyspnea or breathlessness, cough, hemoptysis, and of course, pain in the chest. So first was mentioned dyspnea or breathlessness. So is the medical term for shortness of breath, sometimes described as an air hunger. It is an uncomfortable feeling. According to classifications, we classify dyspnea on physiological and pathological, and also according to the course, it is divided on acute and chronic. So, acute dyspnea could be due to, in the first place, asthma. Also, it may be due to a non-pulmonary problem, anxiety, or pneumonia, or due to choking, or allergic reaction, or in serious loss of blood resulting in anemia. Chronic dyspnea could be due to chronic obstructive pulmonary disease, asthma, also obesity and heart problems, and interstitial pulmonary fibrosis. Next complaint is cough. So a cough is a sudden, usually involuntary expulsion of air from the lungs with a characteristic and easily recognizable sound, although it is known as the most common symptom of respiratory disorders. So a cough can be classified by its duration, character, quality, and timing. The duration can be either acute, of sudden onset, if it is present less than 3 weeks, subacute, if it is present between 3 or 8 weeks, and chronic when lasting longer than 8 weeks. A cough can be non-productive or dry, or productive when phlegm is produced that may be coated up as sputum. It may occur only at night, then it's called nocturnal cough, or during both night and day, or just during the day. So if patient present with the cough, you have to ask about next features. Duration, for example, for how long it is, for days, for weeks, months, or years. The course, is it constant, worsening, intermediate, or diurnal variation? Triggers, maybe it is allergens, irritations, swallowing, or poison. Dry or productive it is. And other characteristic features such as shortness of breath are combined with the cough, chest pain, also tightness, loss of weight, fever, and sweating. If the patient complains of cough with sputum, you should try to determine the amount of sputum during one fit and during entire day, the time of day when sputum is expectorated, posture of the patient at which cough is provoked, and properties of the sputum, the color, odor, etc. Next complaint is hemoptysis. So it is blood-stained sputum. Is the coughing up of blood or blood-stained mucus from the bronchi, larynx, trachea, or lungs. In other words, it is the airway bleeding. So it can be due to lung cancer, tuberculosis, bronchitis, pneumonia, and a lot of cardiovascular conditions. Next complaint is chest pain. So chest pain appears in many forms ranging from a sharp stab to a dull ache. Sometimes chest pain feels crushing or burning. In certain cases, the pain travels up the neck into the jaw and then radiates to the back or down one or both arms, for example, due to myocardial infarction. Many different problems can cause chest pain. The most life-threatening causes involve the heart and the lungs. Many lung disorders can cause chest pain, including pulmonary embolism, pleurisy, collapsed lung, and pulmonary hypertension. Now, examination plan of respiratory system. Mainly, it consists of inspection, which is divided on static and dynamic, palpation, percussion, which is divided on comparative and topographic, and finally, auscultation. So, as was mentioned, inspection consists of static inspection and dynamic inspection. So, on static inspection, first of all, we have to take a look on the shape of the chest and symmetricity of the chest. So, normal shape of the chest are normosthenic, hypersthenic, and asthenic chest. Characteristic features of normosthenic chest is that the shoulders are under the right angle to the neck, supra and infraclavicular fossa feebly expressed, the ribs are moderately inclined, the interspaces are visible but moderate expressed, and the most important, how can you check it? By measuring the epigastric angle, and in normosthenic chest it is near 90 degrees. But in hypersthenic chest, for example, this epigastric angle exceeds 90 degrees. And in asthenic person, this epigastric angle is less than 90 degrees. Now, pathological shapes of the chest. They may be caused by the chronic pulmonary diseases, for example, due to emphysema, which is called emphysematous or barrel chest, or caused by pathology of costoskeletal part of the thorax, or caused by various deformities of the spine as a result of injuries, tuberculosis of the spine, or rheumatoid arthritis, for example. So first is emphysematous or barrel shape of the chest. It observed in emphysema of the lungs. A barrel shape is normal during infancy and often accompanies normal aging. The lung seems to be as if at the inspiration phase due to decreased elasticity of the lungs. The volume of the lungs increases, the natural expression becomes difficult. Expiratory dyspnea arises. So accessory respiratory muscles active participate in the breathing act, especially sternocleidomastoideus and trapezius. Elevation and lowering of the entire chest during breathing become evident. Next is paralytic chest. So the shoulders are sloping, clavicles are asymmetrical and pronounced, supra and infraclavicular fossa depressed, the ribs are vertical as the interspaces are wide and depressed, the shoulder blades are not on the same level. Epigastric angle in this case is like in asthenic person, less than 90%, and marked atrophy of the chest muscle is visible. Paralytic chest is found in exhausted patients, in general asthenia, constitutional undevelopment, and in the patient with long-standing pulmonary pleural diseases such as pulmonary tuberculosis and pneumosclerosis. Next is rachitic or pigeon chest. So it is a result of abnormal skeletal formation in childhood in the patients with rachitis. The ribs meet an acute angle of the sternum. The costal cartilage thicken like beads at points of their transition to bones. So the sternum is displaced anteriorly, increased anteroposterior diameter, resembling the keel of the bow. Next are funnel chest and poveated chest. So funnel chest is depression of the lower portion of the sternum near the xiphoid process. This deformity can be the result of abnormal development of the sternum or prolonged compression effect. Compression of the heart and great vessel may cause murmurs. Therefore, the funnel chest is also called cobbler chest. In older times, such shape of the chest was found in shoemaker adolescents and was explained by permanent pressure of the chest against the shoe. But exact cause is now unknown. Poveated chest is almost the same as funnel chest, except that the depression is found mostly in the upper and the middle part of the anterior surface of the chest. This deformity occurs in syringomyelia, a rare disease of the spinal cord. And final are pathology shapes of the chest caused by various spine deformities, for example, scoliosis, kyphosis, lordosis, or kyphoscoliosis. Now, the symmetry of the chest. Normally, the right and left side of the normal chest are symmetrical. The clavicles and shoulder blades are on the same level. The supra and infraclavicular fossa and interspaces equally pronounced on both sides. Next is dynamic inspection. So here we have, first of all, to calculate respiratory rate. To determine respiratory type, we have to look on the participation of the chest wall in the breathing act. Also, we check the respiratory depth and respiration rhythm. So there are three types of respiration: thoracic, abdominal, and mixed one. Participation of the chest wall in breathing act have next meaning. Poor movement of the chest on one side only always indicates pathology on the side, so it may be due to dry pleurisy, hydrothorax, pneumothorax, ribs fractures, intercostal neuralgia, and myositis. Now, dynamic inspection, calculation of the respiration rate. So in adults at rest, it should be from 60 to 20 types per minute. Pathological rapid breathing above 20 per minute is called tachycardia. Pathological slow breathing below 16 per minute is called bradycardia. So tachycardia can be, for example, due to inflammation, tuberculosis, compressive atelectasis, obstructive atelectasis, pulmonary emphysema or pulmonary edema, dry pleurisy, acute myositis, etc. Bradycardia may be due to cerebral tumor, hemorrhage, meningitis, and brain edema. Also may be due to uremia, diabetic or hepatic coma, and drug-induced respiratory depression. Now let's listen to the normal respiratory rate, and then we will compare the sounds with tachypnea and bradypnea. Now tachypnea. And finally, bradypnea. All right. Now respiration depth. The volume of the inhaled and exhaled air at rest in adults varies from 300 to 900 milliliters. So shallow respiration is characterized by short inspiratory or expiratory phases. Shallow breathing is usually rapid. Deep respiration is characterized by elongation of the inspiratory and expiratory phases. As a result, deep respiration is slow. So here I want you now to listen to Kussmaul respiration, which is deep rapid breathing with marked respiratory movement accompanied by noisy sound. And most often it is due to diabetic, hyperglycemic, hyperketonemic coma or uremic coma.
Like here is breathing. Kussmaul breathing. This is breathing that you see with diabetic ketoacidosis. He's a little bit altered. He's a little bit slow to wake up. They can be pretty severe.
Now, respiration rhythm. So respiration of healthy person is rhythmic and characterized by uniform depth and approximately equal duration of inspiratory and expiratory phases. So it should be regular. If it is irregular, it may be due to apnea or temporary arrest of breathing, or periodic. They are Cheyne-Stokes respiration, Grock's respiration, and Bayot's respiration. So let's listen to Bayot's respiration. Cheyne-Stokes respiration. And finally, Grock's respiration resembles Cheyne-Stokes respiration, except that shallow respiration occurs instead of apnea. Now, next, our step in examination plan is palpation of the chest. So palpation of the chest has three potential uses: identification of the tender areas, assessment of the elasticity of the chest, and finally, assessment of tactile fremitus. So identification of the tender areas consists of Carefully palpate from the first interspace on the anterior chest, then along mid-axillary lines and along the spine on the posterior chest. Normally, it should be painless. If it is painful, of course, we have to mention where exactly patient felt this pain. Next is assessment of elasticity of the chest. So, assessment elasticity by pressing the chest in anterior-posterior and lateral directions. The elasticity of the chest normally is elastic, not normal, it is rigid. Next is assessment of the tactile fremitus, and this examination really has significant meaning because if tactile fremitus sound or vocal tactile fremitus sound is decreased, it may be due to pleural effusion on pneumothorax or pleural thickening or obstructive atelectasis or very thick chest wall due to edema or subcutaneous fat. If it is increased, so it may be due to lobar pneumonia, lung infarction, pulmonary tumor, tuberculosis, and compressive atelectasis. And when it absent, so when significant amount of fluid or air are accumulated in pleural cavity. So let's watch how to perform this examination.
Tactile fremitus. Tactile fremitus is a palpable vibration of the chest wall resulting from speech. Tactile fremitus may be performed in two ways. The first way is to place the ulnar surface of your hands against the patient's chest wall and ask them to repeat the phrase 99.
99, 99, 99, 99, 99, 99.
The second way is to place the palmar surface of the fingers against the chest wall and again have the patient repeat the phrase 99.
99, 99, 99, 99, 99.
The test should be repeated from the front, again going from top to bottom. Again, have your patient say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99. All right. Now, next is percussion. So, as I mentioned already, it consists of comparative percussion of the lungs and topographic percussion of the lungs. So, comparative revealing of percussion sound features on symmetrical areas of the chest. Those areas are supraclavicularis, clavicularis, subclavicularis, axillaris, suprascapularis, interscapularis, and subscapularis. Now, topographic percussion aimed to determine lower borders of the lungs, upper borders of the lungs, active and passive mobility of lower borders of the lungs. So percussion of the chest, this is the objective method of examination based on evaluation of sound types during the knocking of the thorax. So comparative percussion, the aim containing lung tissue will give a clear pulmonary sound, which is also called resonance in percussion. So comparative percussion helps to determine where the underlying tissue are air-filled, fluid-filled, or solid. So the common cause of percussion notes changes include decreased airness of the pulmonary tissue or full absence of air in a part of the lung, increased airness of the pulmonary tissue, pleural accumulation of fluid, pleural accumulation of air, for example, due to pneumothorax or hydrothorax. So the main symptoms based on comparative percussion are clear pulmonary sound in healthy person, dullness due to infiltration of lung tissue, for example, in tuberculosis, pneumonia, pneumosclerosis, or lung cancer, accumulation of liquid in pleural cavity, or stony dull in case of large pleural effusion, pleural thickening. Next abnormal sound which may be heard about the lungs is tympanic one. So this sound is maybe due to increasing the air capacity of the lung tissue in case of bronchial asthma or lung emphysema, or formation in the cavity within air in lung parenchyma, for example, in case of abscess in the lungs or bronchoectasis. And finally, accumulation of air in pleural cavity due to pneumothorax. So, topographic percussion, as was mentioned, we have to measure or check the upper borders of the lungs, lower borders of the lungs, and respiratory excursion. So, upper borders of the lungs, lung apex anteriorly. Normally, the upper level of the lung apices is 3 to 4 centimeters above the clavicle. Now, lung apices posteriorly. Normally, the upper level of the lungs apices is about the level of the C7. Upper borders of the lungs displacement. What is the meaning of it? So the upper borders of the lungs can vary depending on the amount of the air in the apices. In increased airness of the pulmonary tissue, for example, due to emphysema or attacks of the bronchial asthma, the apices increases in size and move upward. In decreased airness of the pulmonary tissue, presence of connective tissue in the lungs as a result, for example, of inflammation in tuberculosis or pneumonia, the apices decreased in size and move downward. Now lower lung borders. In order to determine the lower lung borders, percussion is carried out along topographic lines. And now, respiratory excursion. So, respiratory excursion may be estimated by noting the distance between the level of lower pulmonary borders on full expiration and full inspiration. So, respiratory mobility of the lower border of the lung is decreased in inflammatory processes, decreased elasticity of the pulmonary tissue due to emphysema, or pleural effusion, adhesion, or obstruction. So, identify respiratory mobility by right mid-clavicular, mid-axillary, and scapular lines, and also by left mid-axillary and scapular lines. And now let's watch video how to perform percussion of the chest.
I know that there are many different ways to do this. I favor you're putting your hand firmly against the patient's chest, not keeping the other fingers up, because I think it's harder to form a good seal. So push the fingers in, seated nicely in the intercostal spaces, and you're trying to aim for the middle of this phalanx. And it's important to keep your fingernails short in order to percuss successfully. Your wrist must be loose, and if you get all these things going, you will have a nice percussion stroke that will serve you very well. You're detecting a slight difference between left and right. And that is quite normal. That is the area of superficial cardiac dullness.
All right. And now one more method of examination is auscultation. It really has significant meaning for respiratory system examination. So the auscultation of respiratory system is an inexpensive, non-invasive, safe, easy to perform, and one of the oldest diagnostic technique used by the physician to diagnose various pulmonary diseases. So we auscultate the lungs on posterior view, anterior view, and in axillary regions. So lung sounds maybe that are heard during auscultation may be main respiratory sounds or breath sounds. They are normal or maybe abnormal, and may be also heard adventitious or added sounds, which are always abnormal. So main respiratory sounds or breath sounds are next one. Normal tracheal sound above the trachea, normal bronchial breath sound above the bronchi, bronchovesicular breathing sound, and normal lung sound or vesicular breath sound above the lungs. So let's listen to the bronchial breath sound. And now let's compare it with vesicular breath sound. And adventitious or added sounds always abnormal, and they are rales, crepitation, or pleural friction sound. So rails are divided on dry and moist. Dry rails are divided on sibilant and sonorous. Moist or crackles are divided on fine bubbling rails, medium bubbling rails, and coarse bubbling rails. Now let's listen to the sibilant dry rails or wheezes. And now let's listen to the moist rails. So, the most common cause of dry rails include bronchial asthma as a leading factor, bronchitis, of course, and tuberculosis or tumor of bronchus. The most common cause of moist rails include bronchopneumonia, bronchoectasis, cavity in the lungs, and pulmonary edema due to the left ventricular failure, for example. Now, crepitation, abnormal sound, as a distinct from rails, crepitation originates in the alveoli. So crepitation is generated in alveoli when they contain small amount of liquid secretion. Crepitation is slight crackling sound that can be imitated by rubbing a lock of a hair. So crepitation is only heard during the height of inspiration. Crepitation is mainly heard in acute lobar pneumonia, in infiltrative pulmonary tuberculosis, in lung infarction, in congestion that develop due to insufficient contractile function of the left ventricular myocardium. By its acoustic properties, crepitation can often resemble moist fine rails that are produced in fine bronchi or bronchioles filled with liquid secretion. Differential diagnostic signs of rails and crepitation are next. Moist fine rails are heard during both and inspiration and expiration phase. They can be intensified or disappear after coughing, while crepitation can only be heard at the height of inspiration. And finally, it does not change after coughing. Next, or last abnormal sound is pleural friction sound, which is also called pleural rub or friction rub. It is diagnostic added sound of pleurisy, or due to pneumonia or rheumatic pleurisy, or pleural tuberculosis, or tumor, or effusive pleurisy at the period of rapid resorption of exudates. So pleural friction sound can be differentiated from the fine bubbling rails and crepitation by the following signs. The character of rails is altered, or rails can disappear for a short time after coughing, while pleural friction sound does not change in this condition. When a stethoscope is pressed tighter against the chest, the pleural friction sound is intensified, while rails do not change. Crepitation is only heard at the height of inspiration, while pleural friction sound is heard during both an inspiration and expiration phase. And finally, if a patient moves his diaphragm in and out while his mouth and nose are closed, the sound produced by the friction of the pleural due to movement of the diaphragm can be heard, while rails and crepitation cannot because there is no air movement in bronchi. Let's listen to pleural friction sound. And now we came to additional methods of examination, which helps us to confirm our opinion about patient's condition. So here we have laboratory and instrumental. So due to respiratory system disease, most often laboratory methods which we are using are sputum examination, blood gases test, and examination of pleural fluid. Instrumental methods are X-ray of the chest, spirometry, bronchoscopy, bronchography, and of course, in specific cases, we can use NCT and MRI. So, sputum examination. A sputum test, also known as sputum culture, is a fast, relatively painless test which helps laboratory technicians study the bacteria or fungi that might be growing in the lungs and causing the production of the sputum. So this can help them find the cause of the illness. Microscopic study of the sputum. It is microscopic study amount, character, color, consistency, and admixture in the sputum are assessed. In microscopic study, we divide sputum elements into three main groups: cellular, fibrous, and crystal formations. Bacterioscopic study, we check microbes, their virulence, and drug resistance can be identified by bacterioscopic study. Now, symptoms for sputum analysis. We may prescribe this examination if patient is having cough, fever or chills, fatigue, muscle ache, breathing difficulties, and chest pain. Results of sputum analysis may be such as signs of bronchitis, a lung abscess, pneumonia, tuberculosis, chronic obstructive pulmonary disease, or cystic fibrosis. Examples of possible results. For example, mucopurulent sputum is commonly found in bacterial pneumonia or bronchitis. Scanty, watery sputum is often noted in atypical pneumonia. Rusty sputum is seen in pneumococcal pneumonia. Foul-smelling sputum is associated with anaerobic infection due to aspiration or lung abscess. Next examination, very important, arterial blood gases test, which is also called ABG test. So, arterial blood gases test measures the acidity or pH and the levels of oxygen and carbon dioxide in the blood from an artery. So, this test is used to find out how well the lungs are able to move oxygen into the blood and remove carbon dioxide from the blood. So blood for an ABG test is taken from an artery. Most other blood tests are done on a sample of blood taken from a vein. After the blood has already passed through the body's tissues, where the oxygen is used up and carbon dioxide is produced. So with help of this examination, we can check partial pressure of oxygen, partial pressure of carbon dioxide, pH, bicarbonate, and of course, oxygen content and oxygen saturation values. So, ABG test, ABG test or arterial blood analysis test is an essential part for diagnosing and managing the patient oxygenation, also ventilation status, and acid-base balance. Next examination, also very important, is pleural fluid analysis. So pleural fluid analysis is a test that examines a sample of fluid that has collected in the pleural space. When fluid collects in the pleural space, the condition is called pleural effusion. So abnormal results may indicate possible causes of pleural effusion such as heart failure, infections, severe malnutrition, trauma, cirrhosis, or even cancer. Next examination, X-ray examination of the chest or radiography. So many structures of the chest are readily visible on a chest X-ray, but others are difficult to see. In fact, some important structures, such as the phrenic nerve, are not visible at all. Other anatomical structures, such as pleura, only become clearly visible when abnormal. So this study is prescribed in the following cases for the determination of the disease, such as pneumothorax, pneumonia, chronic obstructive and oncological disease of the lungs, to identify the causes of pain in the chest, shortness of breath and cough causes, to establish foreign bodies in the stomach, respiratory organs, and lungs, to identify lung damage, fractures of the ribs, including problems that provoke the appearance of pulmonary edema, and in case of cardiological pathologies such as cardiomegaly or heart failure. So, photos of lung in healthy and sick patients reflect the same structures. For example, pulmonary fields of the left and right lung. The shadow of the heart we can see here. In the upper part of the picture, at the top of the image, are visible, of course, the clavicles, right and left one. The lower part at the bottom, the diaphragm dome. Diaphragm dome on the left and the right side is visible, and the shadow of the ribs is projected on the pulmonary fields. Now, next examination method is spirometry. So spirometry is a standard test the doctor used to measure how well the lungs are functioning. The test works by measuring airflow into and out of the lungs. So we indicate the spirometry for the following reasons: to diagnose or manage asthma as the most important reason of it, to detect respiratory disease in patients presenting with symptoms of breathlessness and to distinguish respiratory from cardiac disease as the cause, to measure bronchial responsiveness in patients suspected of having asthma, to diagnose and differentiate between obstructive lung disease and restrictive lung diseases, to follow the natural history of disease in respiratory conditions, to identify those at risk from pulmonary barotrauma while scuba diving, to conduct preoperative risk assessment before anesthesia or cardiothoracic surgery, and of course to measure response to treatment of conditions which spirometry detects. So the two main pathological conditions of the pulmonary system are obstructive and restrictive pulmonary diseases. Obstructive, when patient cannot get the air out but can easily get it in, and restrictive, when patient cannot get the air in but can easily get the air out. So we can assess the above-mentioned condition with forced exhalation volume in 1 second measurement, forced vital capacity measurement, and the most important is ratio or Tifno-Parnell index, ratio between forced exhalation volume in 1 second and forced vital capacity. Next method of examination, instrumental method, is bronchography. So it is a radiological technique which involves X-ray, the respiratory tree or bronchi, after coating the airway with a contrast dye. So it is an internal part of the diagnosis of diseases of the bronchi. So contrast dye is a substance that makes the organ more visible on the X-ray. Currently, the most used is iodine combination. So the most used and most comfortable materials for this procedure are catheters and probes. So indications for this examination are bronchoectasis, hemoptysis, if you don't know what is the reason of the bleeding from respiratory tract, tracheoesophageal fistula, tumors, and chronic pneumonia or bronchitis. Next method is bronchoscopy. It is endoscopic technique of visualizing the inside of the airway for diagnostic and therapeutic purpose. So an instrument on bronchoscope is inserted into the airway, usually through the nose or mouth, or occasionally through a tracheostomy. So aspiration of retained secretion in patient with airway obstruction or postoperative atelectasis. Also, we use this method to control of bleeding within the bronchus, removal of foreign bodies that have been aspirated, direct visualization of the tracheobronchial tree for abnormalities, for example, tumors, inflammation, or strictures. If we want to take biopsy of the tissue from observed lesion, in aspiration of deep sputum for culture and sensitivity and for cytologic determinations, and of course, direct visualization of the larynx. Now, students who are in Zoom, please put the pluses in chat. I will check your presence by myself. Please do that. What I want to tell you, first thing, that you don't have to be brilliant to be a doctor student. You have to be hardworking and have good character. That is what makes good doctors. And of course, you have to take any chance to receive knowledge. So thank you, students, very much for your attention for today. Do not forget that the chapter you are learning today is going to save someone's life tomorrow. Here are suggestive readings. If you want, you can take the picture of the slide, and also additional literature for your use with videos if you want to check those videos by yourself. This lecture will not be available on MISA. We perform lectures only online. That's all, students. Now, once again, students, thank you very much for your attention. Do you have any questions to me? All right, no questions. So thank you, students. Bye-bye, and have a nice weekend ahead.
Thank you, ma'am.
Bye-bye.
Thank you, ma'am. Have a nice day.
Thank you. Thank you.